Hello, and welcome to Bite Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on dermatitis herpetiformis under the section of dermatology. So what is dermatitis herpetiformis? It's characterized by IgA deposition in dermal papillae, and it's a disease of unknown antigen. As for its epidemiology, it's quite common in the Northern European, particularly Irish ancestry. It's rare in Black and Asian populations and is usually common in young people between the age of 15 and 40. With regards to its signs and symptoms, it typically presents as an intensely pruritic and stinging skin or rash. And the textbook definition of this that can frequently come up in your MRCP examination is an eruption of small blisters on an erythematous excoriated papules. It typically affects the extensor surfaces of the body. So here, this is a classic picture of dermatitis herpetiformis that's affecting this patient's elbow, as you can see. And as described earlier, these are classically small blisters on an erythematous baseline. So in terms of investigating someone with possible diagnosis of dermatitis herpetiformis, as any other dermatological conditions, it's really important to pay particular attention towards history and examination. Once that's done, hopefully then you would have a rough idea about what's going on with the patient. So you need to be thinking about this condition as a potential differential diagnosis. You then move on to blood tests, and it's particularly important to arrange for serum autoantibodies, including tissue transglutaminase or anti-TTG. Then you can consider doing a skin biopsy. On pathology of the skin biopsy, you will be observing neutrophil microabscesses in the dermal papillae or frank blistering disease at the dermo-epidermal junction. Sometimes, due to its link with celiac disease, it's also preferred to do a jejunal biopsy to be confirming and looking for the celiac disease associated with this condition. And importantly, indirect immunofluorescence in this condition is always negative, and that's quite opposite to other blistering diseases such as bullous pemphigoid and pemphigus vulgaris. As for its treatment, the treatment of it is really gluten-free diet as the long-term gold standard of treatment. However, for active disease, sometimes sulfate drugs such as dapsone can be considered. Dermatitis herpetiformis is one of those conditions that has quite a few associations, and the biggest one of them is gluten sensitivity in the form of celiac disease. However, sometimes those patients may be asymptomatic. It's also associated with other autoimmune conditions such as thyroid disease and type 1 diabetes. Importantly for MRCP, especially your written examination, it's really key that you guys are familiar with the HLA associations with celiac disease and dermatitis herpetiformis. And those include HLA DRB1, HLA DQA1, and HLA DQB1. The prognosis of dermatitis herpetiformis is generally really good if the patient is able to have a restricted diet. And long-term dapsone may be used, especially if adherence to a gluten-free diet is quite difficult for the patient. And in terms of risk and complications, really the biggest risk factor is the possibility of long-term risk of small bowel lymphoma. Okay, let's do some questions. A 28-year-old lady with a history of type 1 diabetes presents to the dermatology clinic with a 6-month history of an intensely itchy small blisters over an erythematous base affecting her knees and elbows. She also reports intermittent abdominal pain and bloating over the same period of time. Given the likely diagnosis, which of the following statement is incorrect? A. She's likely to have raised anti-TTG levels in her serum. B. Indirect immunofluorescence is always negative. C. Gluten-free diet is the long-term treatment of choice. D. Skin biopsy will most likely show neutrophil microabscesses in the dermal papillae. E. The condition is most common in the Chinese population. Looking back at the vignette, hopefully you have realized that you are dealing with dermatitis herpetiformis. There are multiple pointers towards this in the question stem. And these include that you're dealing with a young lady who has a history of autoimmune disease in the form of type 1 diabetes. And she's presented with not only an intensely itchy, small blistering disease over her extensor surfaces of elbows and knees, but also with 6 months history of intermittent abdominal pain. So making you guys think about the possibility of celiac disease in here, and then hopefully getting the diagnosis of dermatitis herpetiformis a bit easier. And if you recall from our session today, the correct option is E, which is the incorrect option in here among the choices. And that's because the condition, as you know, is most common in the Northern European, especially the Irish community. And option A, B, C, and D are all completely correct. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.